As part of my responsibilities at CIHI, I oversee the primary health care information program. So today I'm going to speak about standards as an enabler and use the context of what we've learned in primary health care information. There we go. So just to set the business problem or the challenge, in primary health care today, it represents a huge part of our healthcare activity. But there's minimal data, certainly at the systems level, for analysis other than what's available for billing and some survey data. The good news is we, as a country, have been investing heavily in EMRs, and that progress is moving across the country, and we're reaching a critical mass of users, although in variable amounts depending where you are in the country. So Ontario and Alberta, for example, have reached quite high levels of penetration. And in our own learnings at CIHI, for a number of years, we ran a program where we extracted data for EMRs, cleaned it, and then sent it back to providers in the form of feedback reports. Based on that experience, we found that we couldn't build a scalable business model from a pan-Canadian perspective as we have with some other data reporting systems. So I'll talk to you a little bit about what we're trying to do about that and some of the current and future activity. So at CIHI, one of our key activities is being a developer of PanCanadian Standards, and we've certainly been in that space for primary care EMRs for about 8 years, and we've developed a minimum data set that's evolved, and that's been based on feedback from both providers and from jurisdictions. Our most recent version of the standard is a smaller set of data elements, and I think we talked about that yesterday, that you really need the focus. So this is a set of 45 data elements, and then we've also added to that a set of pick lists for some things that are harder to code in EMRs, such as diagnosis, health concern, reason for visit, that kind of thing. And we map these to various coding standards. So our hope is that by creating a little bit of organization within EMRs, that data can be combined with other data in EMRs, such as the more free text data, and that great insights can be gained from that data. Over the last year, we've been working with Canada Health Infoway on a readiness assessment of jurisdictions in terms of their readiness to adopt and support end users in using the EMR content standard. The good news from that assessment is that there's a strong commitment to primary care and using the data from EMRs in a health system use type context. And we found that all jurisdictions have some room to move in the area of structured data for EMRs, but based on sort of what their historical pattern has been of investment and where they're focused on EMR adoption, there'll be a different pathway within each jurisdiction to achieving a greater level of structure. When we talked to providers, they didn't say no to structured data, but the plea was to align that with other quality incentives and other things they're doing to create the natural efficiencies that need to happen to make their workflow smooth and to allow them to care for patients as their first priority. The last thing that we've been involved in over the last year is we've been testing the standards. So we've got two projects going on in Ontario. One of them is a business intelligence approach, and the other one is a direct approach where we've taken the standard, implemented it at the point of care, and in both approaches, we've taken the data and analyzed it and provided calculated indicators and provided it back to providers to show them how the data that was provided from their system translates into usable or not data for analysis of what's going on at their practice level. So we hope in the coming year to do more of those types of engagements to learn more about the usability of the standard and how we can refine it and work with folks to evolve it in their practice settings. That's it. So I'll pass it over to Stan, who's going to talk about privacy.
Thank you. So Joan Roch sends her regrets. She would have loved to have been here to talk about this topic. Yesterday we heard about privacy as a barrier. And today we're going to talk about privacy as an enabler. This is going to be interesting. So I think there's a general agreement with regards to the importance and the value of secondary use, of using health information for secondary use. And that is reflected in the vast majority of privacy legislation across the country. So privacy legislation actually supports and enables the use of health data for analysis of the health system and research. So legislation is not necessarily a barrier. Legislation also sets, though, the expectations and the obligations that go along with the use of that data for health system use. It also defines the roles of the custodians as being responsible for the protection of the information, the personal health information they collect on individuals. So who are the custodians? Typically, folks who, your clinicians who are using their EMRs. So they are the custodians. They have the accountability and responsibility to protect that information. Yet, they're sharing that information with other entities for secondary use. They still have those responsibilities in legislation. What we've seen is that the challenges have more to do with how we interpret legislation. How do we arrive at that common interpretation? You may have 16 different health system use or analytics initiatives, and you may have 18 different interpretations of legislation and what that means. And that's part of the challenge that we're facing. What constitutes suitable safeguards? We often hear in legislation, you need to put suitable safeguards in place, appropriate safeguards. What are those? How do we arrive at a consensus? That's part of the challenge. A perfect example is how robust is the algorithms that we are using for anonymization and de-identification? Are they robust enough? Are they robust to stand the test of time, a number of years? So these are things that we have to ask ourselves. So Infoway has been fairly proactive over the number of years with regards to this topic, health system use. We've produced a couple of papers, the Big Data Health Analytics paper that you can consult, and that talks about what is big data, what are the recommendations, suggestions, how it can be used, the value proposition. That's all documented in that paper. There's also another paper called Embedding Privacy into the Design of Electronic Health Records to Enable Multiple Functionalities. Well, that's a paper that we've co-written with the Office of the Information Privacy Commissioner in Ontario and Canada Health Infoway, and it talks to the need and the efficiencies with regards to analytics that are available to us once we have access to electronic health records. So it's actually encouraging us to use health information for health system use. And it also encourages us to integrate the privacy by design principles as we're building our analytics solutions. And the last document we at Infoway and others we like to refer to it as the Common Understandings document. So this was a document that was created by the Health Information Privacy Group. Well, what is the Health Information Privacy Group? It's affectionately known as HSU. It's really representatives from all of the ministries of health and territories across the country. And it's the folks who are essentially responsible for the privacy portfolios in those jurisdictions. So we have all the privacy geeks together in a room, policy geeks, and we've arrived at a series of common understandings. In the first iteration of this paper, we had 33 common understandings. And we recognize that we still have a bit of work to do. And so what I'd like to do today is talk to you about that work that we've been doing. So in 2012, they set up a subcommittee, a secondary use subcommittee within HSU. And it was tasked to support Canada's provinces and territories by providing information that can guide them towards common goals and appropriate use of health information for analytics. They began with an environmental scan, and that scan was deemed beneficial in terms of understanding existing secondary use governance practices right across the country. So they focused on several areas of interest. I'll just run through a few of these. Health authorities and EHR agencies, legislation for electronic health records, personal health information authorities, data sharing agreements, secondary use governance maturity models and formal governance models across the country, data warehouses, major data holdings, research platforms, de-identification policies, procedures, and research ethics boards. So some of the findings and conclusions. Well, we found that there's considerable variation in approaches with regards to the maturity of governance models across the country. The processes that they use vary tremendously. Some jurisdictions have ad hoc governance models and their policies and procedures are not even documented. But we also recognize, or at least the jurisdictions recognize, the interest in improving their secondary use governance and felt it was imperative for increasing the availability of electronic health information and to provide it in a consistent and timely fashion for secondary use. So obviously each jurisdiction has a different mix of legislation and policy, right? And they have different practices with regard to how they govern and manage personal health information and secondary use. What we found is that there are a few jurisdictions that have distinct governance structures in place, but very few of them are dedicated just for secondary use. What they've tended to do is to leverage the REB structures that they have within their jurisdictions and use that for the governance of secondary use. There are some examples of a different approach. So Alberta, British Columbia, Saskatchewan, and Manitoba have created committees to serve as proxy decision makers for custodians and trustees, and 3 other provinces are considering similar approaches. So this is really an interesting initiative in these jurisdictions where they're trying to harmonize the governance structures and all the policies and procedures that go with secondary use. So most jurisdictions in their legislation, custodians are most likely to have control over personal health information. And they have the authority to share that personal health information for authorized uses. As I said in previous slides, legislation permits health system use and research. But the custodians are still responsible for that. And in some jurisdictions, the custodians may be responsible for the de-identification of personal health information. So most jurisdictions, we also found, do not have centralized data holdings for secondary use. But we're starting to see a shift. We're starting to see some jurisdictions put that in place, and we're starting to see jurisdictions actually federate data holdings within regional health authorities into a more provincial structure. So all jurisdictions have indicated that they support research platforms, and Alberta is currently working on developing a personal health analytics network, which will act as a data repository for researchers. And it'll provide one data store with seamless access for data from health authorities. We're also seeing jurisdictions that are adopting the concept of research data centers. So in 2012, in New Brunswick's legislation, they're allowing for the building of a research platform which will have administrative and record level data with protected identifiers. But this data center will also allow for the cleansing and validation of the data and allow the integration of data from other areas such as education, immunization. So one of the other important things that we found in our legislative review was that typically in legislation, once data is de-identified, it's no longer considered personal health information. Therefore, not subject to the same protections, not subject to the requirement to obtain consent from an individual for its use in analytics. So that's an important thing. De-identification responsibilities vary between jurisdictions. And for many jurisdictions, de-identification is the responsibility of the custodians or the ministry. Right? So it's not the research organization, it's not someone else. And the formal de-identification policies and guidelines are not harmonized even within jurisdictions. So that's a challenge in itself. There is good news though out there. In Alberta, when we're referring to their health analytics network, they're actually developing a standard process for de-identification of information. So we are making progress in that area. So once we finish the environmental scan, the next step of the HIPCHI subcommittee was to come up with common understandings. So in our original document, we had 33 common understandings that touch on a whole bunch of issues. We now have 25 common understandings that deal with the governance of secondary use. Okay, so what are common understandings? Well, they're really common solutions to common problems that are faced by jurisdictions. They reflect a consensus of all the privacy geeks in the room, the policy geeks, and these common understandings relate to the governance of secondary use. So we've separated the common understandings into three categories. There are foundational principles and governance of secondary use, and then processes related to secondary use. And so we've got a couple here in terms of foundational principles. Pretty simple stuff. You need to have the authority and a clearly defined purpose for secondary use. Okay, that's straightforward. We also recognize that we need to establish some type of governance structure for the sharing of information across jurisdictions. So it's great to do analytics within your jurisdiction, within your region, but we also recognize that we better set up some type of governance structure. We want to do pan-Canadian analytics. So that was one of the conclusions. Sorry for the eye test here. I'll read this out. This is an example of one of the common understandings that we have. And it says, it's a common understanding that jurisdictions should have governance for secondary use which is structured, has clear roles and responsibilities, and is composed of appropriate representatives with the necessary skills and knowledge. Well, that's easier said than done, but some jurisdictions are doing that. So when you have health information custodians that are responsible for the protection of personal health information, and they're sharing that with ministries or other organizations for research, they typically need to be at the table when we're talking about the governance structures and setting up all those common policies and procedures. So let me, for the sake of time, just move to the summary. So once we've developed, what have we learned after we've developed these common understandings? Well, all jurisdictions place a high value on the ability to use and share information for secondary use. We see that there's considerable variation in strategies and practices for accessing personal health information, and this requires a flexible approach to governance. Some jurisdictions use health authorities, others use centralized data warehouses. It's a mix, even within a jurisdiction, so the governance processes need to be flexible. The lack of standardization regarding policies and tools may affect the value, the efficiency, and the level of privacy protections associated with health information as we're using it. De-identification policies, as I said earlier, are inconsistent within and across jurisdictions as to who performs de-identification, how it's performed, what are the acceptable techniques and algorithms. All these things need to be worked out. Again, good news stories is, in Alberta, they're currently developing a standard process for de-identification. And the same for Ontario, where they're developing guidelines for de-identification of ministry information assets. So these common understandings, it was felt, would help jurisdictions arrive at common solutions to the governance challenges associated with interpreting legislation. So privacy legislation is not necessarily the barrier. The challenge has more to do with the varied or lack of governance. And as we can see, many jurisdictions have started addressing these issues. All right, thank you.
Good morning. So we're going to take a slightly different turn here and talk a little bit about some of the technology, if you will, capabilities and enablers. And I thought we'd take a slightly different approach to start. My colleague, when we talk about what does it actually take and what are the types of capabilities we need to deploy to actually use analytics to change the course of healthcare, if you will, a very smart colleague of mine by the name of Dr. Graham Hughes uses this sort of analogy of applying the right horses to the right courses. And we illustrate that concept in this way. I'm going to use a shopping example. So I need a pair of pants. I hate shopping, by the way. And so I'm going to park as close as humanly possible to the store entrance that I'm getting to. I will make a beeline to Holt Renfrew. I will make no side trips. I will get my pants, and then I will retrace my steps as quickly as humanly possible to get back out of the mall. On the other hand, other customers, and sometimes patients, take a slightly different route. So my worst nightmare, I affectionately call her Mom, will take the same mission, but she takes a much more circuitous route. She goes in and out, she gets detoured, she might look in different places, and along the way, not only, she also gets to Holt Renfrew at some point. In the US, we call it the Gap, in this example, but she stops in a lot of other places, spends a lot of other money, does a lot of other things along the way, right? Takes her sweet time. So the course that we take to basically achieve the same objective is very, very different. In the retail setting, obviously, my value to the mall or the store and my mother's value are very, very different. And the way that you actually want to communicate and entice us in, right, is going to be very, very different as well. So we use this as the sort of metaphor to talk about what do we need to do and think about when we think about delivering personalized medicine, right, to customers to patients, right, within the healthcare system. What are some of the tips and tactics we can take from retail, for instance? But I also think this is a really good metaphor when we think about what are the analytic and data capabilities we need to put in place to allow us to use analytics to drive the business. Right? Because when people say, what are the key enablers that I need to put in place? What's the ecosystem? Right? The answer is, it depends. And I don't just say that because I'm a long lifetime consultant, right? It depends on both the types of information that we're creating, right, or wish to consume or acquire, and it depends on how that information is intended to be used and consumed. So if we're delivering information for research purposes or folks to help drive policy, right, the way that information is both analyzed and needs to be served up for decision making looks very different than the way that I'm going to deliver information directly to a clinician in the clinical practice or even to a patient, right, directly to help them drive their own course. So how we actually look at and what we need to do is to align our analytics and data capabilities with the course that we're trying to chart. And I think that the real truth here is that to a very large extent, we do have the technology, the analytic and the data capabilities to essentially be able to interrogate, right, and exploit all of the different types of data that exist in our organizations today. And we also have the capabilities now to deliver that information in a variety of formats and through a variety of mechanisms to enable frontline decision making, right? The technology and the data capabilities really aren't a barrier, they are enablers and they exist. So, we can look at examples of how we're addressing these sorts of issues and using data that exists in our environments today in ways that we might not have before. Somebody yesterday said that doctors like to express themselves, right? We're talking about, how do we put in notes and capture ideas about patients? But the truth is, so do our patients. We like to express ourselves as well, and we don't do that, right, in bits and bytes and drop-down buckets. And so we work with organizations like UPMC, a large medical center in the US, or United Healthcare, and we're using things like text analytics and natural language processing to be able to really listen in to patient conversations. So for instance, when I call into a helpline or call into a nurse line, to basically understand what is the patient's sentiment and what is possibly their propensity, right, for behavioral noncompliance, right? What is the likelihood that they aren't going to take their medication, aren't going to follow the course that we've set for them, and might require some other types of intervention for good behavior, right? How do you get my mom to go straight to where you need to go, right, without all these sort of, detours? And by using and applying these technologies, we can both, and now we're getting very close to even in real time, while somebody's on the phone, make a determination based on looking at their demographic and clinical profile, but also not only what they're saying, but how they're saying it, determine whether I should actually offer up a home nurse. Do I need to actually look at other mechanisms to get them to take their medication? Right? Should I give them a medicine bottle with a beeping cap? Or for someone like Kimberly, do I just need to answer a question and leave her alone? Right? How do I actually customize it? So we're now able to look at some of this sort of dark data and be able to apply that in really interesting ways. Yesterday, we also saw another speaker, an example, and he put up the picture of the ICU, right? And we have a lot of discussions about things like the Internet of Things, right? Healthcare is custom made, right? We are poised and ready for the Internet of Things because we already have a lot of things, right, that capture the data and the metrics. And so we can do things now like we work with a NICU unit and we apply machine learning algorithms in real time to actually assess and analyze data coming off all the monitors on a NICU bed, right, on these very small, tiny infants. And we can actually predict, right, based on historical information and current real-world factors, when an infant is developing an infection 48 hours before any clinical symptoms present themselves, with an incredibly high degree of accuracy. So we can actually now start to preventatively treat an infection that, if we waited 48 hours, will actually emerge full-blown in crisis situation. Now, this is a fundamentally different sort of approach, because we have to, agree to really believe the insights and then apply them somewhat proactively. But this is a really interesting, right, a new way to start being very proactive in our care. It's enabled by machine learning. It's enabled by these sort of high performance and real-time analytic solutions. And that's actually using that, right, preventively in the healthcare setting. But we also partner now with firms like Genia, and I probably pronounced that wrong, so if this gets up on the web somewhere, I apologize to them, where we actually now can do that in the home care setting as well, using wearables. Right, so conceivably in the future, at some point, I will have my Fitbit or my watch or whatever that may be, and it will notice that perhaps I'm looking a little depressed in my systems, and maybe I should go to bed early, right, because I may be developing a cold. Who knows, right? So now we can actually start to push that preventative care to the patient as a doctor as well. So these are all ways, right, that we can actually now apply the data and information available to us in new and interesting ways. Really quickly, you talked about partnerships and collaboration, and Jeff's going to talk a little bit more about this as well, but a lot of the data platforms, the Hadoops of the world, and our ability now to deploy information and make it available in the cloud and through mobile solutions also makes it possible for us to do things like our Optum Life Sciences collaboration, which is to support real-world evidence-based policymaking. And what we're working with Optum Life Sciences to do is actually collect massive de-identified patient sets and make them available to people using a cloud-based hosted environment so that they can actually come in and look at the opportunity for an impact of therapies for specific cohorts, and do that in a way that's not system, right, or hospital or whatever specific, and do that. So these are all things that we can now do. So again, depending on what the course is and what we're trying to deliver and achieve, really the technology and the analytic and data capabilities, right, we have all the horses we need to chart these courses. And I would argue that in a lot of cases, the key enabler that organizations aren't looking at enough is not so much the technology and the data and analytic infrastructure, right, although we point to that a lot as the barrier, it actually tends to be the business infrastructure. Right? So I'm going to say that the other enabler, when we're talking about technology and infrastructure enablers, is what is our business infrastructure that supports analytics? There's an inherent assumption when I say that we can match sort of the analytic and data capabilities to the course, right? When we say let's match the horses to the courses, that we actually know what the course is, or we're prepared to design it, right? So one of the things that we see in organizations, even in healthcare and outside of it, that they do very, very well is they're very focused and deliberate in what problems they're trying to solve and the approach they take to doing that. And they're very discrete, we call it an analytic sort of portfolio approach, in actually identifying the analytic and data requirements and capabilities by deconstructing what information they need to either inform policy or strategic decisions, or what information and questions they want to answer and help to optimize, right, existing operational practices, based on deconstructing what my existing business programs and priorities and initiatives are, and matching the analytic capabilities to those, right? And from there, looking at what's the data that's required to support those types of analytic capabilities. And then, by the way, with that portfolio and looking at that set of information, I can actually now start to prioritize and create an analytic deployment roadmap that takes into account alignment with business value and value creation. It looks at our ability and our willingness to actually consume the information, right? Insight's great, action's better, right? So what is not only, yes, we got an insight, but how willing and able are we at this point in time to make the systemic business process and application changes to make use of information? And also, what is actually our technology and the data required, and do we have that, and what are the steps that we need to take? So one of the first things, if we think about infrastructure enablers, is do we have a deliberate way to create a structured and methodical analytic agenda and roadmap, right? The second component, and there's lots of things that we could talk about, but the second seed I'll sort of drop with you today is that we need to be very cognizant that the course of analytic delivery is very, very different than traditional application development. And it's actually very different than traditional BI deployment, right, i.e. reports and dashboards, where we can actually identify what the metrics are, define what the formula is, A plus B divided by C, right, and spit that out. And there's a very discrete delivery process for that, right? We define what the requirements are, we go get the data, and then we massage it, wrangle it, beat it into submission to meet the requirement that we have. And we spend a lot of time up front doing that, right? In a lot of cases, then we get to the back end and we realize it wasn't quite what we thought it was, or we can't apply it in the way that we do. So the other thing that organizations are doing is we actually develop a very methodical analytic business process. And we think not just about development of an analytic model, but we look at the analytics as a business process that starts with the ability and the environment that allows us to do some exploration, right, and analysis with data that might be a little bit dirty, might not be perfect, right? We throw it in there quickly, we do a little bit of exploration, and then we sort of put our thumb up and go, does this look like that has probable value? Yes or no? If it does, let's spend a little bit more time cleaning up, addressing data issues, revising that model. And then let's lift our heads again and say, okay, did we find something interesting and actionable? Yes or no, right? If yes, is it something that we're willing to do something about? And if yes, now let's look at what the systemic, right, the business process, the application changes we need to make to implement that and put it into practice are. And if no harm, no foul, we learned something interesting, we move on to the next thing, right? This is an analytic business process that has nothing to do necessarily with just the development of the model. And so if we are actually going to look at what do we need to enable analytic delivery and the use of analytics to change the course of healthcare, we need to look not only at those technology and data capabilities, but also what the business enablers are in terms of the infrastructure that we're putting in place. So with that said, I'll actually turn it over to Jeff, who will tell you how his company is actually using all of these things and putting it together to change the course of healthcare for real.
Good morning. So I'm Jeff Ruby, founder and CEO of Newtopia. This is a really interesting setup. Dennis, now I get it. I've been trying to figure out why I'm invited to a conference like this. I'm the proverbial, likes to shake the tree as a health tech entrepreneur. And Newtopia is a precision health company for disease prevention. And much of what's been discussed, we are currently doing, but as a Canadian startup, we really focus on the US market. So this is really a talk about what's possible, I think, not so much what we're doing here in Canada, but certainly what we're doing in the US, bringing together both the privacy, the data analytics, and all these pieces to deliver real disease prevention services out. And so just as a backgrounder, what's a precision health company for disease prevention? We've created a novel health engagement platform that we deliver for individuals who are at greater risk for clinical obesity, diabetes, type 2 diabetes, heart disease, or stroke, or we look at metabolic syndrome risk reduction. And we deploy that platform out to large US insurance companies and large self-insured employers to reduce the risk of those individuals and ultimately lower cost. And through our work with Aetna, who's a major partner of ours, we've been engaged in a 3-year randomized control trial and are now engaging out to roughly 60 million Americans with our solution. So just to give you a sense of what is possible and what we're doing. So just what's the solution about? The philosophy at Newtopia is that the answer to sustainable behavior change really lies within each individual. You've got to take the time to understand people, to really get to crack their code, and then deliver an experience that's going to be meaningful to change their behavior. And so for us, what we're doing, and then I'll share with you the data that we're looking at behind all of this, is really focusing on Sally here in the middle. She would be your at-risk employee working at a typical US company. By the way, we're talking about roughly 50% of the US population, same here in Canada, 35% have metabolic syndrome today. So this is not a small niche business by any stretch. We're going after probably the largest preventable area of health risk we possibly can. So Sally's been identified either through a voluntary biometric test or through a health risk assessment, of which we glean the data from, to identify those risk factors. And then we really want to understand her in some particular ways. And so we understand Sally through a genetic profile and through a behavioral profile. I'll unpack that a little bit. The genetic profile is not in the typical use. We are dealing with very sensitive personal health information in her genetic analysis, but we're looking at a narrow band of genes that taken together give us an indication of what she may have inherited from her parents that may be having an impact on her weight and lifestyle, namely so she can stop blaming herself and understand that there may be some biology at play. But also, how can we shape the recommendations we provide for her to give her a sense of control over what she should do from a nutrition, exercise, and behavior standpoint? And so we're a genetic engagement company, ultimately, that's really serving this up as a spark for positive behavior change. We combine that with a very powerful behavior analysis, whereby we're understanding Sally's personality type, her motivation type, and her readiness to change. And with both the genetic information and the behavioral information, what we're able to do is deliver Sally an experience that is profoundly personalized. And so we're able to understand what content to prescribe for her, how to prescribe it, who should deliver it, how to gamify it, and how to make it social. And ultimately, that's really what our platform wraps around someone like Sally or the millions of Sallys out in the marketplace. And so the first step is we personality match Sally to a coach, someone we call an inspirator. They are going to meet live online through FaceTime or Skype or Google Hangouts, effectively HIPAA-compliant tools that we're able to use for communications. We are going to identify the right content for Sally and deliver it in a way that's right for her, using some great technology. So she'll have a customized app or web interface that's dynamic and built specifically for her, using real-time data from a cellular scale that we provide to her. So it's really simple. Put the batteries in. It operates on a 2G cellular network that we pay for so that we get the data up to our secure cloud. We'll intake any wearable device, whether it's something she already owns or one that we deploy, so we engage her in active, real-time metrics on what she's doing from an activity standpoint. And then lastly, based on understanding her motivation type, we will curate the right gaming environment for her. So if Sally's a competitor, she's going to compete at Newtopia. If Sally's social, she's going to socialize. If she's financially motivated or recognition-based, we'll identify the right kind of gaming environment and curate it for her. And then lastly, from a community standpoint, we're going to introduce Sally to 15 to 20 people just like her that share a similar age, similar risk factor, similar genetic type that we can pair her with in order to provide a support group and an empathy group to share experiences on how they're going through their behavior change. And the whole goal of all of this is effectively for Sally and the group of individuals she's working with to achieve a 5 to 7% body weight reduction in 12 months. Why that number? All the clinical literature suggests and our own evidence proves that with that kind of body weight reduction, we can eliminate the risk factors that made her eligible for the program, prevent the onset of those chronic conditions, and ultimately save her company in the US who's paying for this an awful lot of money. So what's going on behind the scenes, and I just talked very quickly about that, and I wanted to leave some time for questions for the panel, but we're using an awful lot of advanced data analytics in real time to evaluate how to do this and how to change up the structure of Sally's experience. And so from an input perspective on the clinical side, we have both genetic data that we are evaluating and identifying with CAP-CLIA lab partners in the United States. We have biometric data that we're working with lab partners who are taking the voluntary blood sample from Sally or potentially the health risk assessment and inputting that data into our back-end system. And ultimately, we have our own behavioral profile and assessment that we are managing to identify her personality type, her motivation type, and her readiness to change. So an awful lot of input is coming in about Sally that we're understanding on a regular basis. From a digital layer, talk about the Internet of Things. We like the Internet of Things, and so from a wearables perspective, whether it's an API strategy to connect out to all of the wearable devices out there, whether it be sensors like scales or activity trackers or heart rate monitors, we have that capability and we're intaking that data. And so that's a big component in real time that we're doing. From a human perspective, we are personality matching and connecting Sally to real human beings who are meeting through HIPAA compliant tools to make sure that there's an interface. We have not figured out how to do this without a human being. In fact, we feel that we're really deploying the best of high touch meets smart touch to change behavior. So there's a human element and human data that's going into this. And then from a predictive analytics, perspective, we rely heavily on artificial intelligence and machine learning, expert systems, and I don't like the term big data because no one understands what it means, but I like smart data. And so we like to think that we work with smart data. And all of that is coming together with the choice of our tech stack to really put this solution set together to deliver phenomenal outcomes. And then just finally, so why are we doing it all, and does it work? And it sounds really great, startup in Canada doing all this. Well, we've actually been able to demonstrate with some published evidence just how well this approach works, and when you think of what is possible and put it together, we're actually making a huge dent in preventive healthcare in the United States right now. So through our efforts with Aetna, we recently published the first of our 3-year randomized control trial results in the Journal of Occupational Environmental Medicine, and it demonstrated not only the industry-leading results with respect to clinical reduction and engagement, but some very powerful in-year cost savings for the employers who are paying for this to the tune of roughly $1,500 per person in saved medical costs. And so I guess I leave you with, when you consider everything that's been discussed here and lots of the barriers, sometimes it takes little groups like us to just push through it and say, well, we're just going to do it anyway, find the way, find the market. And now what we've done is found some incredible traction and have an opportunity to start influencing tens of millions of lives. So with that, I leave you with the opportunity to ask any of us some questions, and thanks so much for coming.
Great, that was wonderful. Thank you to all 4 of you. I'll kick things off, but I do definitely want to open it up to the audience. But maybe just some high-level questions to kind of frame some of the discussion. I'd like to start on the data side. Over the years, I've read many, many times that 80% of the data in healthcare is captured as text. And how do we process that? We all understand the value of that coded, structured data has tremendous value in kind of deterministic algorithms. But maybe Kimberly and Jeff, you could focus on it, and then I'd like to hear Carolyn's thoughts as well around how can we use that unstructured data, and is there a value in kind of natural language processing? And do you see that in some of the solutions you're deploying, and is it producing good results?
I'll let you start.
Sure. So I would say we have a profoundly open approach when it comes to data, both structured and unstructured. We think all data is valuable data, and so we like to work with the structured data that's coming in, the lab results, the data coming from wearables, the data that we're gleaning from our participants through their interactions. But we actually think it's the real-time unstructured data that's coming in, sentiment analysis that we're working on. So as we're evaluating the number of inputs on an individual's app, or we're evaluating the kind of communications that they're having with their Inspirator, we're actually gleaning that unstructured data, and that's lending, at least for us, probably more value in terms of just where someone is and what kind of inputs we now need to do to change the interaction. And so I would say being a little bit more creative, and we're ultimately a behavior change company, and so trying to identify behavior just through text is a little bit challenging. I think it's starting to look beyond, and almost it's the metadata going on around human activity that serves as our most valuable tool.
Yeah, and I think we heard yesterday at the dinner keynote even the ability to do things like to interrogate PDFs, right, and find data from that. And we talk a lot, and I think it is important. Yes, we need to standardize around data sets, but if we think about the time and effort and sort of the length, the horizon for actually making those changes, or even to get basic agreement around some of those things, it's a really long time. And in the meantime, we have a lot of what people have termed dark data in the organization today that we really can make use of. So yes, text processing, natural language processing, and all of these types of capabilities, what they allow us to do is take unstructured content and structure it in a way that we can then analyze and then kick back out to people and present to them in a way that makes sense. So we need to look at both sides of that equation. And I think what's actually interesting is now we're looking at things like machine learning that more and more, right, can actually as opposed to us trying to think, how do we actually adopt human behavior so that, as people, so the man looks more like a machine in terms of how we think about and enter data, we're now bringing the machine sort of to think more like and understand the man, right? And so machine learning, we've got ways even now to be able to, in an automated way, go out and pull in all of these different data sources, regardless of whether it's video, whether it's documents, right? Whether it's, you know, audio streams, and in a much more automated way, then be able to do that translation and then serve up the data in a structured way. So I think that if, you know, the work that we're doing around standardization around that data and that is very, very important. However, that shouldn't be a barrier or to actually getting started on using the information that's already there. And like I said, more and more, I think we can now start to apply the machine to understand and work around how we operate as humans, as opposed to trying to make the humans operate in a more, you know, machine-like manner, I suppose.
Yeah, so I think as I said earlier, the goal of the content standard is to create a little bit of discipline about where data is stored, and some of that is actually structured data, but in our experience, even that data was hard to get out of EMRs to do analysis, and then to put a little more structured around things like diagnosis that are probably key elements if you want to mine the unstructured data to glean insights, if you can actually identify your diabetic easily, and then marry that with other stuff in the EMR that's in there, then I think that's where you get the bang for the buck. So it's the exercise isn't to structure everything in EMRs, but just to create some base to work from.
It's not either
Any
or,
follow-up
it's and.
questions on this particular topic of data or not?
A little bit around the standards. So the challenge that we're having with dealing with the EMR vendors is we're saying, okay, we'd like you to give us data or be able to extract data from them. And can we work on what the standard should be? And they're like, well, when there is a pan-Canadian standard, we'll think about it. Like, are you actually engaging with the Telesys of the world who have a big chunk of the market to say, okay, here's a standard, use it, because we're really struggling as to how do we get people to adopt this standard. It's great to have a standard, but how do you get people to adopt it and embed it in their existing technology? Because we have a big footprint already. Like, how do we do that? Because the data extraction from primary care is like one piece up there.
Yeah. So, I mean, the standard has been embedded in part in different jurisdictions through the EMR specifications. I think our experience was with the voluntary reporting system. Even with that, it didn't really affect what providers were doing at the point of care. So I think the standard is almost the easy part once you agree on what you want to measure and you align it with what providers have to collect anyways. It's really around the change management they have to do at the coalface with providers to get them to integrate that into practice. And then there are some other issues around data sharing and privacy and the ability to share data that also have to be resolved. They're not unresolvable. So I think it's a bunch of things working together. So it's not just the standard. It's not just getting it into the EMR systems. There's a whole change management. We do, yes.
Yeah, I also wonder, we tend to focus on standards being driven or the impetus for standards from the inside of the system out. And if we start to look at some of what you're doing, or even, you know, the wearables and the sort of patient as their own primary care physician sort of movement, which we're at just the start of. I think more and more as people get, especially as we look at millennials and younger folks, into looking at an expectation for what kind of information is delivered to them and insights that they can get action to, and what they expect you, even as a doctor, to be able to provide to me mobily and online before I ever get to that. We may actually see an external push for standards, which is because the patient's going to say, this is what I'm expecting to see, and so the providers that are able to do that, you know, will win, and the ability to do that will be based on your ability to actually capture and standardize. So I think maybe too, we need to think outside the box in terms of how do we actually use our, you know, customers as a lever, because there's lots of reasons why we get caught up in our own internal swirl, but I think the driver long term may come outside the system.
And I'll just add that in Canada, where we've seen great progress with structured data and comparable data capture, it's been when jurisdictions have declared that this is what needs to happen. So there's So for example, the DAD and ACRS and other data systems, the great impetuous was when the jurisdiction said, we're going to go this way and everybody's going to do it. So there's a bunch of factors.
Susan.
So just a question or a challenge around, instead of thinking about structured, standardized data and relational structures and all the metadata associated with that, it takes years to develop. Conversation around non-relational, NoSQL databases is a mechanism to accelerate the data capture and then the data analysis on a larger context, not just the health, but the non-health data from that perspective. So any comments on that?
Agreed.
Yeah, we had from Dale Saunders and Health Analytics down in the U.S. Talking Hadoop structures or Cassandra, et cetera. So
Yeah.
see the Googles and the Facebooks.
For sure.
Organizations taking rapid advantage of that kind of stuff.
Yeah, they are, and it's interesting because our traditional approach, I think, to data infrastructure and architecture has been that we sort of value the model, right? We value our ability to structure it and look at that, and we sort of, again, this is another where the paradigm is shifting, where let's model the value of the data and understand that first, and so bring it in its native structures, use these type of mechanisms, right, that allow us to pull it in and analyze it in a non-relational, non-standardized way, and then based on the value that we see and what elements we're really using, let's spend our time and dollars cleaning those bits up and structuring those and presenting those out. So, you know, we're actually putting in a level of effort and time and cost and resources against the data that we're actually using. You know, again, maybe another heretical perspective, but.
Mark, and then we'll take. Go ahead, Mark.
So I love your comment about the outside input, kind of the external forces that are helping to drive. Could you give us some sense of what you're seeing maybe in North America and playing back to what we could be doing in Canada around data and services, sort of the API economy, and looking at how, as organizations, we could be doing more with a partner perspective to expose data, liberate data, and connect the dots? What are you seeing, and what's your wish, I guess, from that perspective for Canada?
Yeah, I think it's interesting because, again, I think we're at the sort of forefront of a lot of that push. One of the areas I think right now, interestingly enough, it tends to be on the research side of the agenda where we're getting really good sort of collaboration and initial work done. So I mentioned, you know, we collaborate with Optum Life Sciences, and in fact, you know, they're a giant, right? You know, in the industry, and they've got an enormous amount of patient data that we're working with to sort of de-identify and serve up, and actually then to make available to a variety, right, of consumers, and sort of that idea of even, you know, monetizing the data for good, if you will, right, and making that available, right, is something, again, that is a push. And so, you know, in a similar vein, we have a clinical trial data transparency initiative, because what we've realized as we work with researchers and whether it's a lot of the pharma companies and things like that as well, where they're saying, yeah, there's a lot of good work going on, and we'd have a much better output and model if we could look at all of it. So by the way, we all agree to contribute to this platform, which is secure, and then we also then compete. So researchers put in proposals and grants, and we give grants for time-limited secure access to that integrated, you know, data set. So there's a quid pro quo, and I think the more that we can sort of look, and we can sort of maybe draw an analogy to how we would do that with even, you know, personalized medicine and things like that. So, you know, again, I can't claim to be an expert on the Canadian health system, or probably the American health system, except for my own personal experiences with it, which have made me very opinionated. But I think more and more where we can find those opportunities for that quid pro quo, which is you give us, you know, a little data and then we get sort of something back, those are the opportunities where I think we'll get the most traction, and people will be willing to break down, as opposed to using the barrier of data privacy and usage and access, because we share data today. We just don't do it, we do it under the covers, maybe. But I think when we have those barriers, a lot of times it's because it's the easy answer and people don't see the quid pro quo. And if I do this and make the effort, what do I get out of it? And even as individuals, if you make it good for me, I'm willing to give you a lot of information, as long as I see it not just for your benefit to sell me more or whatnot, but for my benefit as well. So that's a long non-answer to the question, I think.
Kind of a related question we're talking about
I'm wondering the extent to which you're translating that into business learning. Kimberly, you talked a little bit about the whole business model about customizing that. To what extent are you organizing your data, if you will, into a business learning environment? There's personal behaviors and there's organizational behaviors, and the relationship between personal choice and organizational and social context is absolutely huge. And as you probably know, from a population health perspective. So I'd be interested in how the businesses are translating this knowledge.
Well, I can certainly just share how, so from our perspective, the business learning is really, it's the whole point. We really see ourselves as a flywheel approach where with every new participant we put through our analytics background, we get to learn more and then get to improve the algorithms and improve what we do. It's not too different from an Amazon or a Netflix style model where the more and more individuals you put through, the better the personalization gets. So for us, each Sally that comes through the system improves how we understand each individual, and our approach is this N of 1. So what we're really noodling with in the back is, okay, so for everyone we work on 5 different behavior types, 5 different readiness change models, 6 different behavior types, and over 16 different genetic variations. That's a lot of ways to improve. So with every individual that comes in, we keep improving the arc of success for each individual and get better and better at what we do. And it really starts to serve as a strong neural network for us so that our predictive ability gets better and better. And so I'm not sure if I entirely answered the question, but certainly the point. Oh, yes. Mm-hmm.
The extent to which you're able to pull your information into organizational practice within the context that is the ways of working. So are you using it at a different level in terms of information and able to use the analytic tools to change behavior not only at the individual person level but at organizational health context?
Yeah, and it's probably more of a second generation. I mean, our mandate is we're really being hired to impact the individuals, but we're certainly providing reporting back at the aggregate level on what we're seeing, and then providing some really surface level suggestions on what they could be doing to improve their own internal cultures, in this case around corporate health and wellness. But I would say where we probably need to go next is diving deeper into the analytics so we can improve what they're doing more so than what we're currently doing on the individual level. Yeah.
Any others? Susan again?
I want to relate back. Frank work yesterday talked about harmonization. Like in Alberta, we went from 8 to 3 REPs. But a further step of not just harmonization, but reciprocity concept, where if the agreement between those 3 REPs is if one approves a research application, then all 3 do. So if you're looking at localized data, you can expand that across the province. Mm-hmm. So my question, getting back to Infoway and CIHI around the acceleration of secondary use, is there an opportunity to expand this dialogue on a national level to say if you have an application that's ethically approved at the local level, that it would apply at the national level, so as I build these big databases with consented data and de-identified data, that I can enable research to bring some of the research that's going out of country and bring it back home. That's my question.
So in one of the common understandings, we came up with that generic motherhood statement that we need to coordinate the pan-Canadian sharing of health information for analytic use. That would be a concrete example of some of the things we need to do. But for that to turn into reality, right across the country, all those involved in that particular research initiative would have to agree to support the same policies, procedures. So it's that harmonization of not just the data sharing agreements, the governance things, but it's also in the techniques, policies, and procedures that are used to safeguard that information. Now, if we could arrive at that common understanding at that level of detail, sure, that would be possible. But there needs to be a business driver for that to happen. So we need to have that big opportunity with regards to analytics to herd the cats, get everybody around the table to agree as to what those standards should be. that would be great.
Do you see that as a necessary step to get where, I guess, the aspirations to think about where we're trying to get to for secondary use?
Well, there would have to be some agreement and acceptance of the various policies and procedures from one RAB to another at a national level, yes.
So I guess I would say we have a great experience to build upon, and I'm looking at our chief privacy officer because I don't want to say anything wrong, but in our experience at CIHI of pulling together data from across the country, and we actually do make it available for research purposes. So I think we have a base of experience, and I think we need to build on that base to help define the future. It's a little bit different environment and some different aspirations, but I think the potential is there for sure.
We're getting close to the end of the hour. Any other questions? If not, I have one. It's kind of for Kimberly. You seem to allude to it. Jeff's probably implementing it. Maybe Stanley could comment on maybe some of the security issues. You seem to allude to analytics, software as a service almost. Mm-hmm. And kind of the way I see it and where I sit, they're becoming more and more complex, requiring more and more data from more and more sources. And the only way we could maybe afford to utilize some of these solutions is to maybe think of them as a service. In a sense, CIHI is doing that today and been doing it in a sense for 20 years. Get that data into the cloud, make it available to a broader population, get a better ROI. I'd just love to hear maybe some thoughts on just that concept and maybe some of the risks associated with it, Stanley, around, you didn't use the word security, but we all know you can have security without privacy, but you can't have privacy without security. And a lot of the risk we're seeing today with respect to healthcare data is rooted in cybersecurity issues and hackers getting to that. So even these cloud kind of solutions potentially introduce another security risk.
Yeah, and so when people say, so what's the security risk or things I have to think about when I go to the cloud or online? Really, we've just moved where the problem exists, right? The platform that we're talking about. So we still we have all the same issues and concerns. And truthfully, I think there's a perception that because it's in the cloud, particularly in hosted, external bits, that it's somehow more vulnerable. But I think that the instances of people being hacked within their own walls might negate that concept. But I think the other thing that's sort of interesting is that we tend to think about, if we think about how we develop an analytic model or a predictive model, and the amount of information initially required to create a predictive model, right? So yes, there's a set amount of historical, very detailed data that we need for a period of time to be able to look at, use past behavior and indicators in conjunction with current to sort of say, here's what's sort of predictive, right, in terms of forecasting what's going to happen next. And that's actually really just only required to some extent. We don't need that in real time exposed to sort of the real world, because once we develop the model, we're actually, we use massive amounts of data to develop a model, but then we actually, when we're delivering it in real time, right, against a single patient, we're applying that model against a very small bit of data from the patient that gets aggregated. And the interesting thing is with the behavioral analytics is as soon as we are successful in changing behavior, the model that we use to predict that behavior, right, by definition is no longer valid. And so today we sort of think about also just capturing data ad infinitum, right, for historical purposes forever and ever and every bit that we can. But I think over time what we'll see is we'll capture information for a period of time, and it's sort of like a moving train, right? We'll start to archive and get rid of some of the older stuff as new stuff comes in that's just used to extend or update the model as opposed to continuously just building that store. So I think when we think about that, yes, all those issues are there, but the amount of data that has to be exposed operationally versus from development of the model is different, and so we can have different systems and safeguards in place to allow that to happen and still, safeguard and provide those benefits.
I mean, the security issue is a huge one, and the best example, we work with some of the largest financial institutions in the U.S. and some of the largest insurers, and over the 3 years of our work with that now, there have been 3 different and increasingly stringent security requirements. So it's it's almost as if you finish with one and then they're going to come and create something new, and how to tighten it and tighten it and tighten it because of these fears. And so, certainly the quid pro quo to doing this kind of predictive analytic work and to using this kind of data is that you better be very prepared to walk a fine line on security, encryption and more encryption and more encryption, and data segregation is the name of the game. And we work within a HIPAA compliance world, and so wherever your hosting is going to be, we're constantly on the alert for what is a spiraling upward evolution in security. And I can't say there's a standard, because tomorrow there'll be a new standard as it keeps moving.
Sure.
So it is the opposite side. To being creative means you've also got to spend more and make sure your security's there.
So I find that the comment interesting that, we're just moving the problem, the traditional privacy security issues and challenges we have in our traditional IT environments, they're the same in the cloud, and you're correct, they are the same. I guess where the challenge comes in with regards to cloud computing is it really depends on the deployment model of cloud computing. If you're using a community-based cloud service, so a cloud service that is created and operated for a specific community, a healthcare community, such as services you're offering, then you would hope as a consumer of cloud services that you would be able to perform some type of due diligence, and you would be willing to share that due diligence process, expose your privacy security practices, policies, and technologies, and then build that trust. But if it's a public cloud service, that is totally opaque to everyone.
Yeah.
I have no clue what Google's actually doing in terms of how they're securing my Google Drives. And that's to be expected. So again, it depends on the cloud model. Things like, yes, encryption, absolutely. Who controls the encryption keys? If it's your data, is it you? If that data is shared with 15,000 other organizations, who does that on behalf of? There's a good news story to all of this, though, with regards to privacy and security aspects in the cloud. There are many organizations, the cloud industry is really stepping up to the plate. So you've got something called the CSA, the Cloud Security Association, right? Alliance. And what they've come up with is a whole series of standard practices with regards to securing cloud environments. And the possibility for independent third-party audits. So as a customer of a cloud service, you should be able to ask for the results of those third-party independent audits. Again, build trust in the overall ecosystem of cloud services.
Great, thank you very much. So we're out of time, unfortunately. This is great discussion, so please join me in thanking the panelists for some very insightful views. I'll summarize a few of the ones that I took away in 5 minutes when we get to the main room. So if you could join me in thanking them and join us back in the main room right next door.